The shunt may be at different levels, and all these patients will present more or less clinically in the same fashion. And what is that fashion? You will have cyanosis, you will have clubbing, usually there won't be any heart failure, usually the heart is small, there is an ejection systolic murmur, and there is a single second heart sound. This is the common presentation, what we call as tetrad physiology or physiology of fallow. So these are the various terminologies. So you can have maybe a classical tetralogy, or you can have double outlet right ventricle, or you can have transposition of great arteries, but all in association with VSD and pulmonary stenosis. You can have tricuspid or mitral atresia, you can have single ventricle with PS, or you may have pulmonary stenosis with ASD. The only time that the shunt will be right to left in presence of pulmonary stenosis with ASD is once the right ventricular dysfunction sets in. Even if it's a severe PS, but the right ventricular function is good, the shunt will be almost always left to right. As far as pulmonary hypertension is concerned, here again, clinically, it is very difficult, if not impossible, to differentiate the level of the shunt. And this pulmonary hypertension with right to left shunt is popularly known as Eisenmenger syndrome. Right to left shunting may be at the level of the interatrial septum, interventricular septum, or at the level of the aorticopulmonary level, like for example PDA or AP window. You can have VSD-PH with various anatomical substrates. You can have DORV with VSD-PH. You can have single ventricle with PH. You can have transposition or corrected transposition. So you can have multiple anatomies which produce more or less a similar clinical picture. Now in Eisenmenger's again, you will find that there will be cyanosis, there will be clubbing. Heart failure is not common in the early part. Maybe at the, during the end stage, you can get into heart failure. And then, of course, usually by the time the Eisenmenger occurs, the heart becomes small, but there is a lot of parasternal activity. The pulmonary artery pulsations are very prominent. There is an ejection click, and the second heart sound will be variable. In ASD, it will not be wide once Eisenmenger sets in, but fixity will be preserved. In VSDs, usually the second heart sound will become single, whereas in AP level shunt, the second heart sound will be split closely because of severe pH, and it will still be mobile. So based on second heart sound, probably you can make out whether it is the shunt is at the atrial, ventricular, or great vessel level. As I said, venous admixture, again, the anatomy can be variable. Total anomalous veins, tricuspid mitral atresia, single ventricle, and truncus arteriosus. Transposition, popularly known as detransposition, because you have to understand one thing, that connections and relations are two different things. When we say transposition, you are talking about connections. When the left ventricle is connected to the pulmonary artery and right ventricle to the aorta, it is called transposition. When you talk of relationships, the relationships are in space. So when the aorta is anterior and to the right, it is called D malpost. When it is anterior and to the left, it is called L malpost. If it is anterior straight away, neither left nor right, it is called A malpost, so on and so forth. So very important to understand, transposition means relationship and malposition means connections. Now the first important thing clinically when you get a case of cyanosis is try and find out whether this is a PS subset or PH subset. This you need to deduce in your own mind before you make a presentation to your examiner. And the common dictums, these are not gospel truths or golden rules. These are some of the common clinical things that we come across and we realize whether this is PS or PH. The first is age. Usually, if the age of the child is less than 2 years, it is highly unlikely that this will be a PH-induced cyanosis. Most often, it will be PS. Presence of parasternal heave. Most of the patients with PS kind of physiology will have a silent precordium, whereas those with pulmonary hypertension will show some amount of parasternal heave. Pulmonary artery pulsations are almost always absent in PS-like situation, whereas they will be very prominent in presence of pulmonary hypertension. Long and loud murmur is a characteristic of PS subset, whereas short, absent murmurs is a characteristic of PH subset. Presence of continuous murmur almost always is a pointer towards PS or pulmonary atresia, and the continuous murmur is produced by collaterals. Patent ductus arteriosus, once it gets Eisenmengerized, never produces continuous murmur. Either it will produce a systolic murmur, or if it is a very severe PH, you may have no murmur at all. And then, of course, clinical examination has limitations, so you need to take help of X-ray and ECG and echo to tell you whether it is PS or PH. How should be the approach to a cyanotic baby? I think the approach should be systematic. You cannot randomly see these patients. And when I say systematic approach, you must go by history, the clinical examination, ECG, X-ray, and then other investigations like echo, CT, MRI, and very rarely cardiac catheterization. As Dr. Pelajani very rightly said, that in 2015, very few babies undergo cardiac catheterization if they have associated cyanosis. Now, what do you ask in history which can help you either come to a diagnosis or decide the prognosis or draw a plan of management? So first is age of onset and progression. As I said, if you have an age of onset of cyanosis which is early, it is most likely to be because of PS, and if it is rapidly progressive, believe me that you have to be very careful, because a rapidly progressive cyanosis is one of the medical emergencies. These are the patients, if you don't intervene, may actually spell and cause central nervous system problems. So it's very important to know how progressive are the symptoms of cyanosis. If there is a recent worsening of cyanosis, always look for the precipitating factors, because sometimes by the time the patient arranges for the money and other things, just treating the precipitating factors can really relieve patient of his or her symptoms. And the common precipitating factors are anemia and respiratory tract infection. Believe me, patient with cyanosis, treat the anemia, or patient having infection, treat the infection, and you'll see how beautifully they improve in terms of their clinical profile. If there is a history of spell, again, this is something that needs to be treated on a war footing. You cannot take spell lying down. You cannot say that I'll treat with Ciplar and more propranolol and maybe treat anemia. This means that this patient needs urgent intervention. And most of these interventions, as you know, are surgical. Now, when you talk about other features in history, like for example, if you have Eisenmenger's syndrome, and if you have syncope, convulsions, unconsciousness, hemoptysis, these are some of the prognostic features. Once these symptoms set in, the 5-year survival would be less than 50%. So these are some of the hallmarks on history which can give you a clue to diagnosis, sometimes to prognosis, and sometimes it helps you in deciding how aggressively you are going to manage these patients. Now let's talk about a cyanotic child. First and foremost is where and how to look for cyanosis. This is a very important question commonly asked. So one thing is cyanosis always needs to be seen in natural light and never under tube light. If you see under tube light, you will diagnose every alternate baby as having cyanosis. Very difficult to say with certainty whether there is cyanosis or no cyanosis. The important lesson that you must learn is that whenever you are in doubt, always take a help of pulse oximeter to rule out desaturation. And these are how cyanotic fingers and the clubbed fingers look like. Now let's talk about examination. Some few points. First and foremost, most of these patients will have vitals which are near normal. There won't be much change. The second important thing, as I said, heart failure is uncommon, whether it is PS or PH, unless you have either reached the end point or sometimes with some of the complications like infective endocarditis, aortic regurgitation, hypertension, so on and so forth. But heart failure, more or less, is uncommon. Now in JVP, this is another important question which is asked in exams. What does a prominent A wave in JVP in presence of cyanosis tell you? The simple answer is, it tells you that the interventricular septum is intact. And when I say interventricular septum is intact, it may not be completely intact. There may be a small VSD, but the VSD will be always restrictive. A non-restrictive VSD in presence of cyanosis will never produce A wave. And the corresponding part of A wave in JVP is a presence of S4 in the tricuspid area. So if you hear a S4 or if you see a wave in the JVP, you must say that this is a patient who has hemodynamically intact septum, which means either a perfectly intact septum or a restrictive VSD. If you hear a S4, look for A wave. If you see a A wave, hear for S4. Always see to it that you correlate. In the exams, you need to learn this art, how to correlate and present things and not present them randomly. As far as pulmonary hypertension is concerned, I just said about the second heart sound. It gives you a lot of information about the level of the shunt. Second heart sound, if it is fixed, it is atrial level shunt. If it is moving, it can be either ventricle or great level. If second heart sound is single, most likely to be ventricular. If second heart sound is split but moving, most likely to be a great level shunt. The third thing is about the pulmonary stenosis subset, like tetralogy, double outlet. All these conditions will almost always have a single second heart sound, because pulmonary stenosis is severe enough not to produce any audible event. Now, what do you know, or what do you think would be the relationship between the intensity of the murmur and the type of anatomical subset that you're looking at? The classical teaching is that the length of the murmur is inversely proportional to severity of tetralogy of Fallot. That's a perfectly correct that if you have a long murmur, usually the tetralogy will be mild. If you have a short murmur, the tetralogy will be severe. Meaning thereby that if you have a long murmur, the cyanosis will be mild, and if you have a short murmur, the cyanosis will be severe. Now tell me, if you have a long murmur with severe cyanosis, what do you think? A long murmur with severe cyanosis means that this is unlikely to be tetralogy, and there is an additional admixture. So you have either tricuspid atresia, you have transposition, you have single ventricle. So this is one of the most important clinical clues to your presentation. When you present a case of PS as a denominator, you must see how severe is the cyanosis and what is the length of the murmur. And believe me, you will be right 9 out of 10 times. That if you have a long murmur and if you have a cyanosis which is severe, most likely that it will be one of the complicated anatomies rather than straightforward tetralogy. Now talking about anatomical diagnosis, see, clinically you can only go this far and no further. And even in your presentation, don't try to come to one diagnosis. Always give a differential diagnosis, and always say that, these are some of the limitations. And there are limitations to clinical diagnosis. Try and explore as much as you can, but sometimes you may not be able to put your finger on one single diagnosis. Many of these conditions will look very similar, and that is why in practice, not in examination, in practice, do not waste too much time in getting to the anatomical diagnosis. Know the limitations of the clinical examination and leave anatomical diagnosis many times to echo, CT, and MR. Now something about the X-ray and ECG. I think when you describe an X-ray, there should be a systematic description. You can't suddenly say, there is increased vascularity, decreased vascularity. I think you must go with the situs. So first talk about the abdominal situs, talk about the thoracic situs. Abdominal situs based on the fundic gas, thoracic situs based on the bronchial anatomy, then talk about the heart size, then talk about the vascularity, talk about the pulmonary conus, whether it is prominent, normal, or concave, and most of the times this will give you some clue as to what condition you are dealing with. And if you're fortunate, you will have definite contours or typical contours which will give you some idea as to what you are dealing with. So any one of you, what is this case? This is a newborn with cyanosis. This is a classical boot-shaped heart. You can see that with the apex which is pointed a little upwards and oligemic lung field. So this was a case of tetralogy of Fallot, almost amounting to pulmonary atresia. This is a classical example of a near normal heart size or mild cardiomegaly. You have dilated pulmonary arteries only centrally. Look at the peripheries. Peripheral pruning, or what we call as cutoff. This is a characteristic of Eisen-Menger's complex. Now, just a little diversion. Based on X-ray chest, can you define what is the level of the shunt? Can any one of you tell me that if I show you an X-ray which has a cardiomegaly, dilated central pulmonary arteries, plethoric lungs, that could be VSD, that could be PDA. So there are two structures that you look at, the left atrium and the ascending aorta. If you have a shunt physiology with dilated left atrium and dilated ascending aorta, always patent ductus arteriosus. If you have only dilated left atrium but no dilated ascending aorta, it is ventricular septal defect. And neither dilatation of left atrium nor dilatation of ascending aorta, it is atrial septal defect. Now imagine yourself looking at a child on echo. You will find always in ASD, LA-LV are small, RA-RV are dominant. So small LA, ascending aorta is always small. In VSD, LA is large, but ascending aorta is small. And in PDA, both LA and ascending. So that's one of the ways you can differentiate, but not in Eisenmengers. It's just, I wanted to have a diversion, that's why I said. Can any one of you tell me what this is? TAPVC. Okay. Can any one of you get up and tell me what forms the body of the snowman and what forms the head of the snowman? You know that this is popularly known as snowman in snowstorm. So what is the snowman and what is the snowstorm? No, it has got nothing to do. Yeah, so vertical vein forms what? Only vertical vein can it form the head. No, a confluence is behind the left atrium. The head is right here. So this is the left vertical vein. This is the left innominate vein, and this is the right SVC. So this forms the head. Cardiomegaly forms the body, and plethoric lung fields form the snowstorm. So that is how this entity of snowman in snowstorm. Any one of you? Absolutely. So this is what is popularly known as egg on string appearance. You have cardiomegaly and narrow pedicle. Narrow pedicle forms the string and cardiomegaly forms the egg. If you have normal vascularity, as in this case, this was a patient with intact ventricular septum. If you have plethoric lung fields, it will be with ventricular septal defect. Now just to talk about ECGs. ECGs also will give you some clue as to what kind of anatomy you are dealing with. As you know, right ventricular hypertension is the common denominator in 90% of patients with cyanosis. So right axis deviation is the rule. If you find a cyanotic baby with left axis deviation, think of tricuspid atresia with PS or AV canal with PS. These are the two conditions. Despite the fact that you have right ventricular hypertension, the axis would be leftwards. Similarly, the counterclockwise loop. Q waves in 1 and AVL are uncommon in cyanotic babies, excepting if you are dealing with tricuspid atresia or AV canal. Presence of adult progression of R wave is characteristic of hypoplastic right ventricle, may it be related to tricuspid atresia or pulmonary atresia with intact septum. And one very common pattern which is seen in Epstein's anomaly is called QRS on QRS. It's a notched QRS that you see many times. So any one of you, what is the diagnosis? Leftward axis, counterclockwise loop. So you have either AV canal or tricuspid atresia. How do you differentiate? Look at the R wave in V1. So it's AV canal. You cannot have that R wave in V1 in presence of tricuspid atresia, which has hypoplastic right ventricle. And this is the case where you can see the same thing. Counterclockwise loop, you can see Q waves very well in AVL, just a little bit in 1. Leftward axis, look at the R waves in V1. It's like a typical adult progression of the R waves. So this is classical of tricuspid atresia. Now talking about echocardiography, I'm not going to show you clips. I think all of you have seen clips of tetralogy and double outlet. I think I'll just speak on principles of echocardiography. I think this is one investigation which has revolutionized the management of babies with cyanosis because it is simple, it can be done bedside. Ultrasound so far is not known to have any side effects. The most important thing about echo is that it gives you anatomical information, it gives you physiological information with very high degree of sensitivity and specificity. So it helps you in diagnosis, it helps you in prognostication, and it helps you in planning the management strategy for a child. So it's a great investigation. That is why I say that it has truly revolutionized the management. Now the echocardiography, again, like an approach to congenital heart, should be done systematically and should be done in a segmental fashion. So you start with the abdominal situs, look at the pulmonary and the systemic veins, define the interatrial septum, Look at the AV valves, define the interventricular septum and the anatomy, then look at the left and the right ventricular outflow tracts, the great arteries in terms of relations and connections, look at the branch pulmonary arteries, look at the coronary arteries, and look at the aortic arch. It may happen that some of the information may not be available on echo for various reasons. And if that is the case, you need to resort to other modalities of imaging like CT or MRI to get you the right information. Now, what physiological information does it give you? It tells you the severity of pulmonary stenosis, it tells you the severity of pulmonary hypertension, it tells you about the ventricular function, and it tells you about the direction of the shunt. Now, most often at the end of echo, you will be able to come to a diagnosis and you will be able to draw a plan of management in over 90%. It's only 10% of the patients who will require cardiac catheterization, CT or MRI. Now, when you say that you have drawn a plan of management, what does it mean? It basically answers three questions: to intervene or not to intervene. The second is modality of intervention, transcatheter, surgical or pharmacological. And lastly, the timing of intervention. Whether you want to intervene right away or whether you want to wait a little longer, these are all the things. And other things that you should know at the end of all this is, after intervention, what would be the quality of life and what would be longevity? Because these are some of the questions which will be asked by the families, and when you counsel the families, you better know answers to these questions. I think I'll just spend another 5 minutes on cyanosis in newborn and conclude. Is a cardiac emergency, because that is the only time you may get. The second time you know in a newborn, if it's a duct-dependent circulation, the patient may not make it. And that's why this requires treatment or management on war footing with urgent evaluation on echo. Cyanosis in newborn can be respiratory, neurological, or cardiac. And in order to differentiate the three, I think you must take help of clinical examination, X-ray, and blood gases. If you have intercostal retraction, if you have presence of crepitations or decreased breath sound, if cyanosis improves on oxygenation, if there is associated hypercapnia, you must think in terms of respiratory cyanosis, which will be evident on X-ray if you can see the underlying pathology. As far as neurological cyanosis is concerned, it is associated with shallow and irregular respiration, poor muscle tone, again cyanosis disappearing on oxygen therapy. Whereas cardiac cyanosis is usually associated with tachypnea without much retraction. There are lack of abnormalities of breath sounds and usually associated with murmurs. And chest X-ray is one of the things which can help you differentiate. So these are some of the examples. Agenesis of the lung, you can see severe collapse of the left lung, and you can see the crowding of the ribs there. You may have eventration of the diaphragm, and you may have diaphragmatic hernia. All these are pointers towards respiratory causes of cyanosis, and X-ray chest can be extremely useful. And this is a case of tetralogy of Fallot with absent pulmonary valve in a newborn. You can see aneurysmal central pulmonary arteries, especially the left pulmonary artery with oligemic lung fields. And then, as I said, usually in a newborn, we perform what is called as the Hyperoxia Test by giving oxygen around 3 to 4 liters, either with prongs or with a hood, which will help you differentiate the two. In cardiac cyanosis, despite giving 100% or near 100% oxygen, the PO2 will rarely go above 50. Whereas in neurological and respiratory, you will always see it go above 150. So this is a very important test. Many people, the examiners many times will ask you, what happens if the ductus closes? Yes, if you remove oxygen, most likely that newborns with ductal constriction or oxygen therapy, the duct will begin to open up again. But the best strategy would be to have a prostaglandin on standby, so that even if the duct decides to misbehave, you can give prostaglandins and take care of the problem. Now, last part is about treatment. Pulmonary hypertension with cyanosis, medical therapy is the mainstay, correcting anemia, treating infections and pulmonary vasodilators, either with sildenafil, bosentan, ambrisentan, or combination of all three. At the end stage, when the heart failure sets in, you need to treat with diuretics and digoxin. And I think this is one of the most important things, that when you have irreversible pulmonary vascular disease in presence of a shunt, as diagnosed by clinical examination, ECG, X-ray, and cardiac catheterization, it is better to leave the shunt alone rather than closing it. because Eisenmenger syndrome has a better natural history than primary pulmonary hypertension. As far as pulmonary stenosis with cyanosis is concerned, I think it has a much better outcome than Eisenmenger's. In newborns, pharmacological intervention with prostaglandins can be truly life-saving. In patients with transposition physiology or one of the AV valve atresias, septostomy can be useful if the interatrial communication is restrictive. And if there is a reduced blood flow, then there are various ways you can palliate this child by increasing the pulmonary blood flow, either by doing a BT shunt, doing a PDA stenting in the cath lab, putting a stent in the RVOT in the cath lab, or just doing a balloon pulmonary valvuloplasty. And then you need to decide in PS situation whether you are going to offer this baby a biventricular repair, which is common in tetralogy of Fallot, double outlet transposition, and in some patients with corrected transposition, or a univentricular repair in various other conditions. So this is the last part of my talk, and that is that you must understand that pharmacological interventions have gross limitations in treatment of congenital heart disease, because majority of congenital heart diseases are mechanical problems, and mechanical problems need mechanical solutions either in the cath lab or in the operating room. These are some of the cardiac interventions which can be done, and in the interest of time, I'm not going to bore you with this, and I think I'll just come to the conclusion slide, that cyanotic congenital heart disease is a wide spectrum, having multiple anatomical subsets and having different physiological considerations. One needs to go through a systematic evaluation of these patients comprising of clinical examination, history clinical examination, ECG, X-ray, echo, and then CT or MRI, and cardiac catheterization if the need be. At the end of all this, you should be able to get a complete anatomical and physiological diagnosis. Because these problems are mechanical and mechanical problems need mechanical treatment, the treatment in over 90% is surgical. Only 10% can be palliated or treated in the cath lab. Early referral is a key to successful outcome, because if you let these patients go into hypoxemia, acidosis, sepsis, the chances of good outcome, despite a successful intervention, will be limited. In today's date and era, you cannot say that I did a successful intervention and the patient died. That was acceptable 20 years back. In today's date and era, all technical successes should be converted into clinical successes. And last but not the least, unlike cyanosis in a toddler or in an adolescent, cyanosis in a newborn is an emergency, because that may be the only chance to take care of these babies. Thank you for your patient hearing, and if you have any questions, I'll be more than happy to answer.
Any questions? Comments? There's no questions, please comments. Bharat, in the left axis deviation in a small newborn baby or early infancy, the left axis deviation for the age of the baby can be seen within pulmonary atresia with intact ventricular septum.
Yes.
The difference being
Yes.
that in the tricuspid atresia, the axis is more leftward, more superior.
Right.
Whereas in a pulmonary atresia with intact septum
Right.
is say plus 30 to minus 30,
Right.
which is the left axis for a child.
Child,
for a
absolutely.
baby. So I think one differential should come when you see a left axis deviation is pulmonary atresia with intact septum.
Absolutely.
The other thing is even at L transposition
Right.
can cause the left axis deviation. I think there's a 5 or 6 causes
Conditions.
of left axis deviation in a small child.